So topic for today is luteal phase support. It's pretty easy. I mean, we have tackled the preparation of the patient. We have done with the stimulation of the patient. Now the next stage that's very important is to give adequate luteal support. So I'm going to begin with an introduction as to why do we need to give this luteal support and why is it very important in ART cycles. And then we will talk about what are the various drugs or medication that is given for luteal support. Okay, so I'm going to take you back to this previous slide, being very, very important. We had tackled this part of it when we were doing the stimulation, where we were talking mainly about FSH, LH, and the LH surge, okay, and then followed by ovulation and egg retrieval, okay. Now, what happens is once the LH surge is achieved, it is only after that that there is secretion of progesterone. And this progesterone becomes very important for the endometrial lining. So that lining then undergoes secretory changes, which then helps to support pregnancy. So just to introduce, menstrual cycle can be divided into follicular and the luteal phase, which is separated by ovulation. Both estradiol and progesterone are required to establish a pregnancy. Okay. In ART cycles, ovarian stimulation is very essential, leading to multifollicular development. In spite of the high steroid levels, progesterone levels drop in early luteal phase compared with a natural cycle. So because of the stimulation, the moderate ovarian stimulation and the multifollicular development, we have progesterone deficiency in the early luteal phase. Okay, and this leads to the development of a luteal phase defect. So what we have in ART cycles is luteal phase defect, and it is for this reason that we need to supplement it with progesterone. So as we see here in a normal cycle in this graph, what we see is this is the rise of progesterone. So just at the LH surge, we have the progesterone, which is at its peak after that. And then gradually it reduces and then, falls back to the baseline level if there is no pregnancy. But what happens in a hyperstimulated cycle? In a hyperstimulated cycle, the progesterone levels rise and then fall immediately. So there is a lag. So there is a deficiency of progesterone post the ovulation. And that is the reason why we need to give adequate progesterone to support pregnancy. Dr. Kadir, do you need to translate or this is...
non, si c'est pas clair, est-ce que c'est clair pour tout le monde sur le fait qu'avec les stimulations, on a un déficit de progestérone? C'est bon pour tout le monde?
Claire, c'est bon pour tout le monde.
Yes, very good, good. Okay, it is very clear.
Okay, go ahead. Yeah, okay. Okay, so what is luteal phase defect? Luteal phase defect is a controversial entity since its description as a clinical entity way back in 1949 by Jones. It is characterized by inadequate endometrial maturation due to qualitative and quantitative disorder in the corpus luteal function. So what basically happens is because of the supraphysiological levels of estrogen during the ovarian hyperstimulation, what we have is either inadequate formation of the corpus luteum or qualitative disorder in the corpus luteum, which causes the endometrium to be out of phase or lagging behind. So what we have is the pathophysiology for this luteal phase defect is progesterone is secreted by the corpus luteum, and that is essential for the initiation and maintenance of normal gestation. luteal support remains essential till about the 7th week of gestation. So it's only by the 7th week that the trophoblast acquires the steroidogenic capacity to support the pregnancy. So it's very important that we support the pregnancy up till the 7th week. Normal formation and function of the corpus luteum and optimal endometrial preparation is a prerequisite for both the nidation as well as the progress of an early pregnancy. Okay. And this, the normal function as well as formation of the corpus luteum, is dependent on the follicular and ovulatory phase endocrine events. So what is the corpus luteum function? Corpus luteum is a two-cell organism which is consisting of granulosa as well as the theca cell. And these get luteinized with the LH surge. Okay. So the luteinized granulosa cells, they respond to the LH surge and secrete progesterone for 10 days, after which steroidogenesis stops. And the luteinized theca cells, they respond to the LH pulses by progesterone and estradiol synthesis. And these cells multiply and respond to the HCG stimulation for pregnancy. So it is very important that this progesterone that is secreted by the corpus luteum, which supports the pregnancy for the initial 10 days, after which if the HCG is positive, then the luteinized theca cells, they respond to these LH pulses and produce progesterone as well as estrogen, which then supports the pregnancy further. So in all, the corpus luteum is very important to support pregnancy. Progesterone that is secreted by the corpus luteum transforms the endometrium into a secretory form. It induces the endometrial proteins through the P4 receptors, which allows implantation. So corpus luteum is important not only because it secretes progesterone, it also induces the receptors, and that is what helps in implantation. And the follicular phase E2, the estradiol, is the one that induces the progesterone receptors on the endometrial cells. So excessive or inadequate estradiol will induce either too early or a delayed induction of the endometrial proteins. And that because the corpus luteum function to go into disarray. So the corpus luteum, a fully functional corpus luteum, is very important prerequisite for a normal progress of early pregnancy. Okay, so why do we have luteal phase defect in ART? It's because supraphysiological estrogen levels that is seen in controlled ovarian hyperstimulation protocols induces premature luteolysis. And the follicular phase downregulation may also impair the luteal phase, luteinizing hormone release. Okay. And some protocols, they give only pure FSH, and that will also lead to a relatively low LH value. So what happens is when you are downregulating cycles or you've given a GnRH agonist, which is pretty early enough within the cycle and it is a higher dose, then the LH levels go down so low that this will impair the LH release, the LH surge, and in relation to that, even cause a disarray in the corpus luteal function. Oh, do you want me to stop or go on?
Si ce n'est pas clair, vous pouvez lever la main, hein, comme ça on revient là-dessus, si ce n'est pas clair. Mais tant que les gens ne lèvent pas la main, apparemment c'est bon. Parce que comme il rappelle la fonction du corps jaune, et c'est un peu la physiologie, je pense que c'est ce qui fait que c'est très clair. Il n'y a rien de nouveau. It is good because it's the physiology, they know.
Right, they know, right? I can move ahead, right?
Okay, we can go.
Yeah, okay. Okay. So the low progesterone levels in IVF can be due to the loss of granulosa cells in aspiration. So when we are doing the oocyte retrieval, okay, so what happens is you are injecting your needle into the follicle and then aspirating all the fluid. In that, there can be a loss of the granulosa cells, and that can lead to low progesterone levels. Okay, the GnRH agonists cause a short luteal phase. Okay, so when you give GnRH agonist as a trigger, then that is what causes a very short luteal phase. And because of that, the LH is reduced in all cycles using GnRH agonist. And a sudden rise and very high levels of estradiol and progesterone, they can cause a dyssynchrony in the endometrium. Okay, so these are all the causes. So in short, the IVF, or the process of stimulation or hyperstimulation, is the one that induces the luteal phase defect in an IVF cycle. And it is for this reason that we need to support with high doses of progesterone so that we get a successful pregnancy. So what is the treatment? The treatment for luteal phase defect is to give progesterone supplementation, or you give HCG stimulation. So what is progesterone? It's a steroid hormone. It is mainly synthesized in the ovaries and the adrenal cortex, and it is very important for the reproductive function. Progesterone was discovered as early as 1994, and it was proved that significantly higher pregnancy rates were seen in groups that were treated with progesterone as compared to no treatment. And this was proved in 1994 by Soleiman et al. Through 8 randomized controlled trials. So what are the actions of progesterone? So it stimulates the growth of uterus and stabilizes the endometrium. It maintains the uterine quiescence, which is also very important for implantation to take place. It inhibits the myometrial contractions. So it's the same as acquiring a uterine quiescence. It induces the secretory transformation and increases the vascularity of the endometrial linings for a successful nidation of the pregnancy. So these are the hormonal actions of progesterone. There are also immunomodulatory actions, or the non-hormonal actions, okay? So the immunomodulatory actions are, it causes a favorable shift of the Th1, Th2 balance towards the Th2 type, which is also important. It modulates the chemokines transcription factor, and it inhibits the tissue rejection and protects the conceptus. Okay. In addition to that, it also becomes a uterine relaxant. So it blocks the oxytocin effect of PGF2 alpha and alpha adrenergic stimulation, as well as reduces the contractility and promotes myometrial relaxation. Okay, so the main effects are hormonal effects and the non-hormonal effects, which are immunomodulatory and uterine relaxant. So this helps in the maintenance of the pregnancy. It induces proliferation and differentiation of the stromal cells. It prepares the endometrium for the blast implantation and controls the endometrial development. And it is indispensable for establishment and maintenance of pregnancy. So what are the various preparations that are available? We have the natural, which is the natural micronized progesterone, which is available either as oral, vaginal, intramuscular, as well as subcutaneous injections. The synthetic preparations and most commonly used is the dydrogesterone, which is oral tablet, medrogesterone, medroxyprogesterone acetate, and other pregnanes, which we are mainly using for cycle regulation, gestonorone, and other 17-alpha hydroxyprogesterone derivatives. Again, we do not prefer to use this. Norgestrel and 19-norethisterone derivatives, demigestone and 19-non-progesterone derivatives, and drospirenone. These are mainly used in our oral contraceptive pills. What we mainly prefer to use is the natural macronized progesterone and the dydrogesterone to support pregnancy. So again, what doses are they usually used in? So vaginal pessaries, they are usually given in the doses of 600 to 800 milligrams daily. The gel preparation, 8% or 90 milligrams, which could be either once a day or twice daily. Oral dydrogesterone, which is given as 30 to 40 milligrams daily in divided doses. Sustained release, which can be given is 300 to 400 milligrams daily. Rectal suppositories can also be used, but most of them use the vaginal pessaries. Intramuscular injections or subcutaneous injections can also be used. Intramuscular is available as 50 and 100 milligrams per ml, which is given intramuscular, but they are very painful. The subcutaneous injections are now available as 25 milligrams and 50 milligrams per ml, and these are easily tolerable by the patients. But we have, studies have shown that you require much higher doses to support pregnancy. And these injections, the subcutaneous, also need to be taken daily. So what do we find? Just comparisons between oral, intramuscular, and the vaginal preparations. What we know is oral is an easy route, micronized form, but we are able to absorb only 10%. So it's not very effective. It has the first hepatic pass effect, and it has side effects like sedation and hypnosis. But now there are the natural micronized progesterone, the sustained release progesterone preparations, which are now available, which can be taken orally, and they are found to be equally effective. Okay. Intramuscular preparations, they are reliable, consistent, helps us to achieve a plasma level of progesterone, a consistent level. It gets rapidly absorbed in 2 to 8 hours, and the progesterone levels are maintained for more than 72 hours. But the only drawback is that it is very painful. Sometimes it can even lead to formation of an abscess. So I have a number of patients who complain, in fact, with using the intramuscular injections, and they have the redness and a lump formation even till after they have delivered their baby. So yes, they're very painful. And if you apply any ointment, then it leads to an abscess formation. So we recommend all patients to apply only ice and not to apply any other preparation. So it's not very compliant. And vaginal preparations, it has targeted organ delivery. It helps to achieve high concentrations in the uterus and endometrium because of the first uterine pass effect, which I will show you in my next slide. It has minimal side effects, good patient compliance, self-administration, no prick or needle. Vaginal preparations should not be taken orally. If taken orally, it causes a lot of giddiness. So one never recommend any patient to use the vaginal preparation orally. So this is about the first uterine pass effect, where we see that 1 hour after the application, this is the diffusion, and 4 hours, as you can see, there is really very much of progressive diffusion. So what are the various routes? Now taking each preparation into detail. In the oral, administered in doses of 300 to 600 milligrams in divided doses. Oral progesterone is subjected to the first pass prehepatic and hepatic metabolism, and it is because of this reason that the final availability at the uterus is pretty less. The pregnancy rates were significantly lower with the oral formation. These studies, as shown, studies way back in 1996, 1999, and 2000. And these studies strongly suggest that oral progesterone was of inferior quality. Vaginal administration ensured a much greater bioavailability and less variability. But there have been enough papers recently that have shown, that oral dydrogesterone is equally good when administered in high doses of 30 to 40 milligrams daily, and has helped to achieve pregnancy rates that are similar to those with vaginal and intramuscular preparations. So yes, even I have used it for a number of our patients who have not been very comfortable with the vaginal preparation, or at times they have developed infection with the vaginal preparation, wherein we have shifted them to oral preparations, and they have been comfortable.
I have a question.
Yes, please.
Yes, please. What of utrogestan? Utrogestan, is it the oral route?
It's vaginal. Utrogestan is vaginal. Utrogestan is available as 200 milligrams, and
Yes.
it is vaginal. It's a pessary.
Because some do say that they can still use it orally.
No, that is what I said. The vaginal preparations, if taken orally, leads to a lot of giddiness and headaches for the patient.
Okay.
And in an IVF cycle, we usually want to give higher doses. So in such cases, you know, when you use the 200 milligram utrogestan, you may need to recommend your patient, you know, to put in 3 tablets daily or sometimes 4 tablets daily, okay, to get an adequate dose.
Okay, but it's really actually written on the box that you can go orally or vaginally.
I know it can, but you know, when patients take it orally, then this is a very typical complaint that we receive, that they have suffered from giddiness and headache.
Okay, thank you.
Okay, yeah. So now we come to the intramuscular preparation. So it is administered in doses of 50 milligrams or 200 milligrams. Okay. You can give like usually when we have patients, you know, who are self-cycling, we usually give them around 50 milligrams of IM preparation. In fact, in my practice now, we are hardly using any intramuscular progesterone. We have shifted mainly to just vaginal progesterone or oral progesterone. So intramuscular, you know, I give it maybe once in 3 days or 4 days. And if the patient is not able to tolerate, I do not give it at all. Okay. The progesterone levels, they remain sustained compared to the other routes. Okay. Disadvantage and inconvenience of daily injection, as well as pain and abscess formation. And a number of them also develop allergic reactions at times. So they develop a rash, and that's mainly a reaction to the protein that's present, which is acting as the vehicle of delivery. And it is because of that many are not able to tolerate. So the rash is pretty bad. We have to stop the intramuscular progesterone, you know, and put them on antihistaminics and calamine lotion. Now, I can proceed, right? Do you want to translate or anything, Dr. Kadir?
No.
Or we are good?
Is it clear for everybody? I think.
Yes, it's clear for me.
Because there is no something new. I think it's a reminder for them. Okay, you can continue.
Okay.
It is everybody, no problem.
Yeah. So now comparing intramuscular versus oral. So there have been a number of meta-analyses that were done in 2002 and 2003. And most of them said that IM progesterone conferred the most benefit compared to oral, and intramuscular progesterone resulted in significantly higher pregnancy rates compared to oral progesterone. But like I said, this was way back in 2002, 2003. But now we are getting a lot of recent studies that have confirmed that, you know, whether it is vaginal, oral, or intramuscular routes, we are able to achieve similar success rates. Okay, vaginal, but this is most preferred route of administration. It's very convenient for the patient. It's given as 600 to 800 milligrams in divided doses. The vaginal progesterone, vaginally administered progesterone, has better bioavailability because because of the first uterine pass effect. The vaginal progesterone is equally effective as the IM progesterone. Okay. And it is also available as the 8% gel, which can be used once or twice daily. So the only drawback for the vaginal progesterone is patients do complain of a lot of messiness. It's just because the vaginal progesterone leaves a lot of powder behind, and it does not give a very good feeling, and some of them develop infections later on. So that is the only problem that they face with the vaginal preparations. And in such situation, the gel preparations have helped, because the gel, once it is administered at night, just once daily, it releases the progesterone slowly through the night. And the next day, the patient can just, pour in a lot of water, get the complete gel out, and carry on with the daily activities through the day, and then, insert the gel once again at night. So when do we need to start the progesterone and when do we stop? Okay. So various studies were done to really understand when progesterone should be started in an IVF cycle. So in fact, even when I started my practice, we were earlier, starting the progesterone one day after the egg retrieval. And slowly over a period of time, we realized that instead of starting on the next day, it was better to start the progesterone on the day of egg retrieval. Okay, so once the egg retrieval is done, we begin the progesterone for the patient. And in fact, not only progesterone, there are other medication also that we offer our patients to support pregnancy. So day 6 versus day 3 after egg retrieval, we found that the pregnancy rates significantly reduced. But the day of oocyte retrieval versus day of ET, they found that there was no difference. When do we stop the progesterone? So again, studies were done. Stelling and Penzias and Jacobs and Balan did it in 2003, where they recommended stopping the progesterone at the time of pregnancy test. Costabile in 2001 stopped it at 8 weeks, and Check et al. At around 10 to 12 weeks. And what they found is, when the luteal phase is supported, a serum progesterone of 15 nanograms per ml is aimed for. So if pregnancy ensues, okay, then progesterone is continued till up to 12 weeks. After stoppage of progesterone for 24 hours at 8 weeks of pregnancy, if the serum progesterone level is more than 20 nanograms per ml, then the progesterone can be discontinued. So what we want is an ideal level of around 15 nanograms per ml of progesterone. Okay. And if at all you do want to stop the progesterone, okay, post 8 weeks, because after the 7th week, we know that the baby is able to support and secrete the progesterone. The trophoblastic cells are able to continue the pregnancy. If we want to stop, then after stoppage of 24 hours, do the progesterone level. And if the progesterone level is more than 20 nanograms per ml, you can discontinue the progesterone. So luteal phase support in IVF. This was a nice paper by Elena in Reproductive Medicine in 2015. Where it says that though both progesterone and HCG supplementation resulted in comparable pregnancy rates, the HCG supplementation was associated with higher risk of ovarian hyperstimulation. And progesterone has been used for luteal support by most IVF programs around the world. Vaginal preparations have shown definitely to be equally efficacious and better tolerated than IM progesterone injections. But new data on subcutaneous and oral progesterone is also emerging. And like I said, we already have that. This was in 2015. And in fact, now there are papers which say that subcutaneous as well as oral progesterone is equally efficacious. This paper also said that progesterone supplementation of luteal phase of the stimulated IVF cycle leads to higher pregnancy rates and is necessary for optimal results. And a window of time exists when vaginal progesterone should be initiated. Like I said, you must initiate the progesterone from the day of oocyte retrieval. And vaginal supplementation is best started within 24 to 48 hours after oocyte retrieval. There is no need for serum progesterone level monitoring with vaginal supplementation, as little correlation exists between the serum levels and local endometrial effects or pregnancy outcomes. So you actually don't need to do it during the luteal phase. You do not need to measure the progesterone levels. You can still do the progesterone level along with the pregnancy test. GnRH antagonist cycles that are triggered with the agonist and those that involve fresh embryo transfers should have a modified luteal phase support regimen that includes small doses of HCG or LH preparation in addition to standard progesterone support for optimal outcomes. So what we know is that when we are doing GnRH antagonist cycles, so say you have a patient who is having polycystic ovaries and the estradiol level was high, so you gave a GnRH agonist trigger. But what you found out was that probably, the ovaries were not so bulky, or you do want to do a fresh transfer in that cycle, then you need to give small doses of progesterone. So there is a Humiden protocol that says that along with the vaginal progesterone that you give immediately post retrieval, okay? So after the retrieval, you give small dose of HCG. Okay, so that's given at around 37 or 38 hours. Okay, after the GnRH agonist trigger, you give 1500 IU of HCG as an additional support to pregnancy, and giving that small dose that did not result in ovarian hyperstimulation. Okay, so small doses of progesterone can be given. In the Humiden protocol, you just give 1500 IU of HCG and then continue with the remaining progesterone, and that should be enough to support the pregnancy. It's all clear, right? I should continue?
We can ask the question to the group parce que c'est une phase très importante, ce qu'il est en train de dire pour le transfert frais là. Le fait d'ajouter de la ACG ou également de la progestérone, c'est très important. Si les gens veulent des clarifications, ils peuvent revenir là-dessus. Si c'est bon, on continue. It is good. No question.
Okay,
no.
Okay. So, what are the benefits of progesterone? It induces the secretory transformation in the luteal phase. Okay. By inducing this change after adequate estrogen priming, progesterone improves the endometrial receptivity. Endometrial receptivity is self-limited period in which endometrial epithelium acquires functional and transient ovarian steroid dependent status, and this allows the blastocyst adhesion. Decreased endometrial receptivity is considered largely responsible for low implantation rates. Okay, so progesterone is very important. It also helps to open the window of nidation or implantation. Okay. Now, along with progesterone, okay, we give various other tablets also to support pregnancy. And what is very commonly given is estrogen. Mostly the oral estrogen doses that are administered to support the luteal phase is 2 milligrams to 6 milligrams. So what we do is based on what the estradiol levels are, okay, and based on the endometrial lining for the patient, we usually give between 2 to 6 milligrams. So if you have a patient, who has very low levels of estradiol, like she has hardly made any eggs, okay, and the lining is not so good, then probably you could consider giving that patient 4 to 6 milligrams in the luteal phase to support the pregnancy. If at all the patient has a very good lining, okay, and the estradiol levels is between 1500 to 2000, and you have managed to get good number of eggs, you could give that patient just between 2 to 4 milligrams of estradiol in the luteal phase. Okay. There were a few papers again that said that there was no advantage adding the oral estrogen. Some said that there is a beneficial effect, okay? And Lakis et al. In 2002 and Glacier, they both said that there was a beneficial effect in the pregnancy rate in patients with profound E2 decline, that E2 on day of HCG or E2 on the day of ET was more than 50%. Okay. Now, so what is the role of estrogen and progesterone? Estrogen suppresses the apoptosis of corpus luteal cells by its antioxidant property. Okay. It also influences the expression of HOXA10 homeobox gene, which improves the receptivity of the endometrium. So estrogen is also equally important. Like we said in the first chart that I showed you, estrogen does have a second rise also in the luteal phase along with the progesterone. So we require both estrogen as well as progesterone in good doses to support the pregnancy. And this is what happens in a natural cycle. What is the role of HCG? Administration of HCG stimulates the corpus luteum to produce progesterone. It is ineffective in the presence of inadequate number of LH receptors or a malfunctioning corpus luteum. So if given at the LH surge, there is no increase in E2 or progesterone concentration. But given on luteal day 5, it produces a marked steroidogenic response which remains throughout the luteal phase. Okay, so the administration of HCG, it stimulates the corpus luteum to produce the progesterone. So it is ineffective if there is an inadequate number of LH receptors or if the corpus luteum is malfunctioning. Okay, but that is why, so when HCG is given on day 5, when the corpus luteum is already formed and it is functioning, then the HCG will produce a marked steroidogenic response, which helps to support the luteal phase. Okay, so yes, there are certain protocols and certain clinics that administer HCG to support pregnancy. They give it, you know, on day 5 and again on day 10, where they give small doses. But one has to stop the HCG at least by day 12, because otherwise it interferes with the pregnancy test. So you will get false positives if you give HCG for a longer duration. So the role of HCG is to achieve complete luteinization of the pre-ovulatory follicle. So 10,000 IU of HCG should be the dose, which is then followed by just 2,500 IU or 1,500 IU every 3 to 4 days. The treatment is stopped on the 12th, treatment is stopped after the 12th post-ovulatory day to avoid pseudo-pregnancy. That's what I was saying, right? After the 12th day, do not administer HCG, because otherwise there is no point. By day 15, you are going to do the HCG test to know whether the patient is pregnant or not. So mind you, once in an IVF cycle or even in an IUI cycle, you know, once you document ovulation or once the egg retrieval is done, that's when we begin the progesterone support. And all progesterone support is given for either 12 to 18 days. And at the end of that, a pregnancy test is recommended for all patients. Okay, so you must stop the HCG after the 12th post-ovulatory day. Otherwise, you will get a false pregnancy test. Okay, because HCG has a long half-life. So HCG has a longer half-life than LH. The long half-life of HCG renders the pregnancy test invalid for 7 days after the last HCG injection. Okay. Dr. Kadir, it's all good?
I think it has been a good bit.
Any questions for HCG? No, right?
Yes. If there is an issue, they ask question. And right now, everything is good. It is clear.
Fine. Right. Okay. So now aspirin in luteal phase. Okay. So what is the role of aspirin? Usually what we administer is baby aspirin, which is just...
Excuse me, I have a question, please, on
Yeah,
HCG.
sure.
Okay.
Tell me, after how many days can we use it if we just did an induction of ovulation? If we use
what?
HCG,
Sorry?
if we use HCG first, like 5,000 units to do to induce ovulation, after how many days can we use the 10,000 unit to sustain the luteal phases?
Generally, we do not recommend giving 10,000 IU to support pregnancy because that becomes pretty high. So if your patient is having a large number of follicles, then the patient can go into ovarian hyperstimulation. So when we give HCG to support pregnancy, you give it as either 1,500 IU to 2,500 IU. Do not use more than that.
Thank you.
Okay. Yeah.
Okay.
So can we proceed?
No, I have a question.
Yes, sure.
Okay.
Please, now I don't know whether I have to raise my question now or we are still have to discuss about concerning the patient, the donors, the one who doesn't have a corpus luteum. How are we going to do it? Yes. And the transfer in the donors, the donors patients, the person will receive or receiver on the donors.
Yeah. So when you have recipients, right?
Yes,
like suppose you have it's an oocyte recipient cycle, correct?
Yes.
So what happens is when the lining for the patient gets ready, so you have given the patient estradiol tablets from day 2-3 of menses for the endometrial lining to be formed. Okay. And then once the lining is ready, then to open that window of implantation, we have to begin with the progesterone. Okay. So once the lining is ready, what we do is we start with the progesterone. The moment you start with the progesterone, you open the implantation window and then you plan the transfer. So what is important is that the day of implantation, prior to implantation, studies have shown that you have to have at least 3 to 5 days of progesterone before the day of transfer. So once you have adequate levels of progesterone in the body, then the endometrium becomes receptive and you are able to do the transfer. Okay. So if you have day 3 embryos, right? So what you can do is once the endometrial lining is ready, you begin progesterone, give progesterone for 3 days, and then the 4th day you can do the transfer. And if you have day 5 embryos, so sometimes there are certain clinics that even do a day 3 transfer after giving progesterone for 5 days, which is fine, which does not cause any trouble. And when you have a day 5 embryo, a blastocyst, then you can give progesterone for either 5 or 7 days and then plan the embryo transfer. Okay.
And you still give the HCG.
Pardon?
We don't need to give the HCG since there's no corpus luteum in that case.
Correct. So you don't give the HCG.
Okay.
Because HCG requires the corpus luteum. Okay. And in these like these are FET cycles or they are recipient cycles. So when you are giving oral progesterone or oral or vaginal supplementation, then you give them in pretty high dosages, which is more than enough to support the pregnancy. Okay.
Okay for me.
Yeah, you do not require HCG in such a situation. Okay, so then we come to aspirin in luteal support. So aspirin is administered as baby aspirin, either 75 or 81 milligrams. What it does is it helps to improve the uterine blood flow in the peri-implantation period. Currently, there is no evidence that favors the use of aspirin in order to improve the pregnancy rates for the general IVF population. Okay, so in fact, what we do is in those patients where we are artificially preparing the uterine lining, okay, then along with the estradiol, we give the aspirin to improve the blood flow to the uterus so that we get a good endometrial lining. Okay. And then post that, generally aspirin may not be given because it has been shown in various papers that it does not help to improve the pregnancy rate. Low molecular weight heparin in luteal support. So this is safe and effective. It is thromboprophylactic treatment for women with thrombophilia and repeated implantation failures. Although the effect of heparin on pregnancy was not statistically significant in this study, with regard to numerous benefits of this agent, it is recommended to study its effects in further studies with larger sample size. This was published in 2015. And evidence on the effectiveness of combined heparin and aspirin therapy remains conflicting. So generally, we do not give heparin and aspirin together, okay, because both of them are blood thinners. So what we do in our practice is we give aspirin initially, but then once we plan the embryo transfer and we begin the progesterone, we give the patients low molecular weight heparin. Because with the low molecular weight heparin, sometimes even if they have, either they are, positive for APLAB or ANA, any of the antibodies, then this will be corrected automatically. So just small doses of low molecular weight heparin, which is just 20 units, international units or 20 milligrams, is something that we give routinely for all our patients to support pregnancy along with progesterone. Okay. And those that are then known APLAB positive or ANA positive, then those are the patients where we give the full dose of either 40 milligrams daily or 60 milligrams daily. So in conclusion, the functional capacity of the corpus luteum is dependent upon the normal growth and maturation of the pre-ovulatory follicle, emergence of the dominant ovarian follicle, proliferation of the granulosa layer, induction of LH receptors, endometrial proliferation, progesterone receptor induction, and finally stimulation of the LH surge itself are the prerequisite for a normal luteal function. So complete ovarian stimulation is the one that really decides your luteal phase. Progesterone is the preferred option. Combination of oral dihydrogesterone and GnRH alpha or HCG can be more suitable option compared to vaginal progesterone for luteal phase support in women with vaginal irritation or discharge. It should start within 2 days from triggering ovulation, should end on the day of HCG test, or continued till at least up to 12 to 14 weeks of pregnancy. It is always better to avoid stopping the progesterone on the day of HCG and continue right up to at least 12 to 14 weeks, at least in the IVF cycle, so that we ensure that the patient has adequate progesterone levels. Thank you.